Well, in this week's Cardiology Countdown, we'll talk about anticoagulation and valves, the use of renal denervation for Afib prevention, an interesting combination, and the use of anticoagulation in patients with acute MI who also develop atrial fibrillation. So first up is an analysis from the STS database looking at patients who underwent bioprosthetic aortic valve implantation with or without bypass surgery in about half the patients, and looked at what anticoagulant and antithrombotic regimen patients were discharged on and their 3-month outcomes. Now, overall outcomes were good, a 3% mortality and about a 1% risk of bleeding and 1% risk of embolic events. And they compared the combination patients where aspirin plus warfarin was used in about a quarter of the patients to the half of the patients who were discharged on aspirin only. And found that the combination of aspirin plus warfarin was associated with a lower risk of death by about 20% lower risk and about half the risk of embolic events, but a 2.5-fold increase in major bleeding. And so a trade-off there. Interestingly, about 12% of patients were discharged on just warfarin, and compared to aspirin alone, outcomes were nearly identical with similar mortality and bleeding and embolic event rates. And so this calls out the variability of what patients are discharged on and calls us, I think, to pay greater attention into the relative balance of benefit risk of dual antithrombotic therapy in higher risk patients versus monotherapy. So next up is an interesting small randomized trial in patients with atrial fibrillation referred for ablation, pulmonary vein isolation, where they're randomized to pulmonary vein isolation or that plus renal artery denervation as a way to reduce blood pressure. This was a cohort of 27 patients with resistant hypertension and atrial fibrillation, and half were randomized to the combination of renal denervation or not. They found a very large decrease, about 25-point systolic and 10-point diastolic reduction in blood pressure with the addition of renal artery denervation. And that also produced a greater persistence of sinus rhythm at 1 year, where 69% of these high-risk patients were still in sinus rhythm 1 year later, as compared with just 29% in those who got pulmonary vein isolation alone. So it's a pilot study, but I think one that focuses even more attention on the driving cause of AFib in the patients with resistant hypertension and introduces a novel approach to their management. And the top pick this week is a study from the Action Registry Get With The Guidelines database that looked at patients who present with acute MI and the 7% of those who also had atrial fibrillation. And so two things happening at once. There's about 5,000 patients overall. So interestingly, patients in this cohort, fewer than half of them were sent out on anticoagulation with warfarin. There was a gradient of the percentage of patients discharged on warfarin according to the CHADS-2 risk score, so that ranged from 28% of those with CHADS risk score 0, 34% of those CHADS-2 risk score 1, and 43% of those who were CHADS-2 risk score 2 or higher. Thus, some gradient of risk, but still a lot of under-treatment with respect to anticoagulation. About 15% of patients were treated with triple antithrombotic therapy of aspirin, a P2Y12 inhibitor, and warfarin. But it calls attention again to the use of what is the optimal use of anticoagulation in these high-risk patients that have indications for both antiplatelet therapy and anticoagulation. So for this week's Cardiology Countdown, I'm Chris Cannon.